This is lecture 4, the last lecture in the initial PEAC series. We're going to talk about airway pharmacology, and specifically, we're going to talk about pharmacology through the lens of the critically ill patient. So let's start with induction agents. Now, this is a Scott Weingart quote that I really like. The main goal of an induction agent, and I'd argue any treatment that we do, is to keep a patient alive. So before I give a medication, I need to ask myself, is it going to meet that goal? Now, there are many goals that we think of with induction agents. One, we want the patient to have no awareness. We don't want them to remember this event later. We don't want them to feel pain in the moment. And we'd love to have no physiologic compromise. But above all, if the patient is not alive at the end of this procedure, then the medication did not do its job. I would rather the patient have a slight memory or slight sensation of pain and be alive to complain about it later than have no memory and no life afterwards. So let's think about our induction agents and how we choose them. So we choose etomidate and ketamine primarily because they're generally cardiostable. So meaning they don't have huge cardiovascular effects in patients who are not critically ill. Propofol, for instance, is another induction agent that's not usually used in the pre-hospital setting because it does drop blood pressure even in healthy patients. But it can be safe and given in the right setting. So cardiostable medications in patients who are already in shock can actually precipitate shock. So anticipate that they may have a delay in their onset. And then we're going to talk about considering lower dosing in patients that are hemodynamically unstable. For the most part, we're giving these medications weight-based in boluses during rapid sequence intubation. But when patients are hemodynamically unstable, we want to consider some other factors, like their age. Remember, elderly patients, we may decrease the dose of medication by a third of what we do in younger patients. So don't forget that for these induction agents. If you have a patient who's critically ill and completely obtunded, do they really need a full dose of etomidate or ketamine? Or can a reduced dose potentially do the trick? So why does intubation drop blood pressure? There's two main reasons. One is that they have a loss of sympathetic tone with these induction agents. So although physiologically these are pretty stable for most patients, anything that drops your sympathetic tone, reduces your awareness, can drop blood pressure. So this can be a good thing. But if a patient is only staying alive because of a massive sympathetic surge, then these medications can reduce that surge. Second is what we do after we intubate, and that's giving positive pressure ventilation. Now, this is needed. This is necessary, right? But remember that negative pressure intubation when we're awake is important for two things, not just ventilation and oxygenation, but it's important because it's part of our pulmonary pump. This is what supplies preload to the right atria. So as we take breaths in and out, we're actually dumping a nice bolus of preload into the heart, and this augments our blood pressure. When we give positive pressure ventilation, we're not only filling that interthoracic space with more pressure, but we're also putting pressure against the vena cava, reducing preload. So because of these two things, we need to be very careful about inducing our patients who are hypotensive. So let's look at this study that looked at sedative dose for rapid sequence intubation. And what they wanted to know is, does the dose matter? If I give a high dose or if I give a half dose? This is a 2022 study. So does the dose matter? And they looked at 12,000 patients. So this is a retrospective registry study, not randomized, not controlled, but they just looked at patients with post-intubation hypotension that was less than 100. Now in these patients, about 29% of people who got ketamine had hypotension, and 16% of patients who got etomidate had hypotension. Now, pause for a minute here before you get rid of your ketamine t-shirts. Remember, because this is not randomized and controlled, the patient selection wasn't equal. It may be in this study that people chose ketamine because they thought it would help with hemodynamics. They chose ketamine because they say, hey, when I give ketamine, I get a little bump in blood pressure and I get a little increase in heart rate. But in the setting of patients who are actually hemodynamically unstable, there is some negative inotrope effect to ketamine. And the bump in blood pressure and heart rate that they're getting from the ketamine is actually indirect, and it has to do with them releasing their endogenous catecholamines. So if a patient is adrenally depleted, ketamine may not bump their blood pressure, and they may get hypotension like we see in this study. Now, etomidate also can cause hypotension, but the selection in this wasn't equal. So this study itself is not saying ketamine versus etomidate. It was just looking at dose. We'll talk about some control trials with ketamine and etomidate here shortly. So the dose range actually wasn't half. Like a lot of guidelines say, hey, if someone is altered and hypotensive, they don't need a full dose, just half it. So they actually gave normal ranges. So etomidate is given in a 0.2 to 0.3 range. Ketamine is generally given in a 1 to 2 range. So between 0.2 to 0.3 milligrams per kilogram of etomidate and 1 to 2 milligrams per kilogram of etomidate, there was actually no difference. So no difference in either medication. Now, does this mean that half dosing, a little bit lower than this, wouldn't have any effect? We're not sure. The study didn't look at that. But the low and high end doses didn't seem to have a big effect in this patient population. So the reason we care and we want to be careful about not underdosing these medications is we don't want our patients to have awareness with paralysis. So how often does that really happen, and what are the risks? This 2022 study was a prospective cohort study looking at ED patients. It was called the Awareness Trial. So again, it's observational, but it's prospective. So they were looking at patients as they were recruited, a little less than 400 patients, so relatively small single center study. But in that cohort, about 3.5% of patients remembered being paralyzed. So this doesn't mean that they remembered being intubated, but they remembered waking up and not being able to move. That was about 13 patients. The majority of these, 12 of these patients, received rocuronium. And all of these patients actually had a higher risk of potentially developing PTSD because of the perceived threat. They did this with the survey after the fact. So what this tells me is specifically, if I have a patient I've given rocuronium to, I need to be aggressive about resedating them, because when I give succinylcholine, I can see that wearing off and I'll sedate the patient quickly. When patients are still paralyzed and they may be waking up under that sedation, we need to be really careful. So this is why we should be cautious with half dosing. I still think it's reasonable if a patient is hemodynamically unstable and hypotensive and altered to lower the dose of the induction agent. Preferably, I would like us to all resuscitate our patients thoroughly and then just give them a regular dose of the induction agent and be really careful about post-intubation hypotension. So kind of our cautions with these induction agents. We do still have a caution with etomidate and adrenal suppression. There's not good evidence that we're hurting people with sepsis with etomidate. There's some observational evidence, and honestly, the literature goes back and forth, but I wouldn't say there's anything conclusive about this, but a caution. Now, ketamine, we should be cautious with patients with ACS risk factors and tachyarrhythmias. If someone is in SVT, they don't need any additional sympathetic surge. If someone has cardiogenic shock, I'm not going to reach for the ketamine because I actually don't want the additional tachycardia and hypertensive. And then lastly, any patient who's already in a hypertensive emergency, I don't want to make that worse. So those are the patients I wouldn't grab for ketamine. Now, both patients, adrenal depletion can be an issue. Hypotension can be an issue. And we've seen sepsis as a risk factor for both of these patients. There's some studies that say etomidate's better in sepsis. There's some studies that say ketamine's better in sepsis. But when we look at randomized controlled trials, there's not a big difference. So let's talk about shock. Shock is a lovely anesthetic. So if a patient is already completely obtunded with a GCS of 3, probably doesn't matter which agent you pick, and probably they don't need a full dose of that agent. So this is the population who's in shock, who I'm forced to intubate, who I can't adequately resuscitate. Those are the patients I'm going to go low on my induction agent and be a little more protective. Moving on, let's talk about paralytics. Now, we know the importance of paralytics because paralytics increase our first pass success. The good news is they are hemodynamically stable. So don't ever withhold paralytics due to hemodynamic instability. They increase our success with both direct laryngoscopy and video laryngoscopy, reduce aerosolizing infectious disease, and then also reduce aspiration risks. We should give them in full doses. So sucks can be given as high as 2 milligrams per kilogram, and rocuronium should be given at 1.5 milligrams per kilogram. Why the change with rock? Essentially, the big change is because rocuronium given at higher doses kicks in faster, reducing our apneic period and increasing the speed at which someone is fully paralyzed. The faster they're paralyzed, the less time I have to wait. So use rocuronium in high doses. You can't actually overdose on these medications with the amount that you have in your rig. So it's safe to give high doses. Round up with your paralytics. Now, there's some debate between rock and sucks, and this is something that's gone back and forth. There's t-shirts. It's longstanding. There were some OR studies that showed some longer safe apnea time with rock, but so far there's no difference in any of the large ER studies. So the take home is either medication is fine. Dosing is important for rock for first pass success. Now, if you're going to be using succinylcholine, there's a couple things you do have to think about that you may not have to consider with rocks. So let's talk about the mechanism of sucks and how this could be dangerous for some patients. So let's say a patient with a normal amount of acetylcholine receptors is given succinylcholine. Those receptors are triggered. So this is when you have the depolarizing effect and you see fasciculations. Potassium rushes out of the cells. The patient is paralyzed until the body is able to pump the potassium back in the cell and reset the membrane. Now, some patients out there have acetylcholine receptor upregulation. So imagine instead of those 2 doors to acetylcholine, they have twice as many doors or 10 times as many doors. And when you give them succinylcholine, now all those doors open and a great amount of potassium rushes out. This can lead to hyperkalemia. So who are these patients at risk for hyperkalemia? So there's some badness we have to worry about. Pre-existing conditions with hyperkalemia, receptor upregulation that increases mortality, and then also there's some myopathies we should consider. So the pre-existing conditions are the ones we all probably know, like renal failure. But don't forget there's some medications out there that can cause hyperkalemia too. Spironolactone, which is a diuretic, Bactrim, which is an antibiotic. I've even heard of some incidents of ibuprofen causing hyperkalemia. So keep in mind the patient's medical history and what meds they're taking. Now, disease processes that cause receptor upregulation are things like burns, denervating injuries, crush injuries, and even severe infections. Notice all of these conditions have to be going on for more than 3 days. This is because the body needs time to create more receptors. That upregulation doesn't happen overnight. So a burn or a paralyzing stroke or injury that happened today, it's safe to give Suxin. But if it's been more than 3 days, then we need to be cautious. Crush injuries for their own reasons can be cause hyperkalemia, but definitely more than 3 days ago, we can have receptor upregulation. And even patients with severe infections who've been bedbound for a long time. And then lastly, don't forget about muscular dystrophy and patients with idiopathic myopathies. Giving those patients succinylcholine has been shown to increase their mortality by almost 30%. So there's some badness to consider. They call the fasciculations a complication, but honestly, I always found this helpful. When the fasciculations stop, then you know the patient's paralyzed. But remember, if they have pre-existing hyperkalemia, it can be really dangerous to give succinylcholine. Bradycardia can be caused by sucks, but it's usually transient. It's more likely in pediatric patients. And some patients can have prolonged neuromuscular blockade. In the setting of RSI, that's not really problematic. Don't forget about malignant hyperthermia. So if your patients become hyperthermic or tachycardic after intubation, get their pressure, get their temperature, and let the hospital know so we can give them dantrolene. And then masseter muscle spasm or trismus can happen with succinylcholine. This is more common in kids and more likely in underdosing. So round up, give that nice 2 milligrams per kilogram. If you still get masseter muscle spasm, just give some rock and then you should be able to intubate just fine. Now, patients with severe obesity are ones we need to be a little careful with in regards to the dosing for our induction agents and our paralytic. So, medication dosing for neuromuscular blockers should be total body weight. This is not because it's lipophilic, but it's to reduce underdosing. A patient who has morbid obesity is at risk for hypoxia, they're at risk for peri-intubation cardiac arrest, and they have lower first pass success. So we want to make sure they're fully paralyzed just for the point of safety. So full body weight dose. Now, our induction agents, on the other hand, are functioning on the cardiovascular system. So give them in the lean body weight. And you don't need to do a formula here. You don't need to even use your ventilator chart. Just think, what is the skinny person on the inside? If they look like they weigh 400 pounds, but probably they should weigh 200 pounds, dose them on about the 200 pounds. It doesn't have to be an exact science. Just avoid overdosing with total body weight with those induction agents. So the take home here is go easy on the sedatives and go high on the paralytics. Sedatives are important for patient comfort and to reduce any trauma for the patient. What they do reduce the sympathetic surge, and even our cardiostable medications can induce shock in unstable patients. Paralytics, give them high, give large doses. An alternative to RSI is delayed sequence intubation. So think about this as a procedural sedation for pre-oxygenation. So I would do this in a patient who I'm having trouble pre-oxygenating because they're altered. So the idea is that I give a dissociative dose. So start low. I'd use ketamine. This is not the time to use etomidate, and I wouldn't use benzos because those can knock out our respiratory drive. So a nice low dose of ketamine, a 1 to 1.5. Honestly, start at 0.5 and give aliquots of 0.5 until the patient is just cooperative enough to pre-oxygenate. Then take some time to optimize them. Get that non-rebreather on flush rate, or get the CPAP or BiPAP on. Resuscitate their blood pressure with fluids and pressors if you need. And then once the patient's safe to intubate, paralyze them. Because remember, the paralytic is important for first pass success, and it reduces the incidence of aspiration. Use your apneic oxygenation. And in the case of a patient, with an asthma exacerbation or something like that, use a big ET tube. Otherwise, standard size ET tube supply. So delayed sequence intubation has been gaining in popularity, and definitely we've had some increased evidence on it. So this is an interesting study that was done in a trauma triage. It was randomized and controlled, and it was critically injured patients, if you will, who were hypoxic and they were altered. So they're having trouble with pre-oxygenating them. So it was just 200 patients. So small study, but an interesting group because it's agitated ED trauma patients specifically. So one group is randomized to standard RSI and one was randomized to DSI. So for RSI, they pre-oxygenated them as best they could for 3 minutes. Then they gave both ketamine and the paralytic. For delayed sequence intubation, they gave ketamine and then pre-oxygenated them for 3 minutes and then paralyzed them after pre-oxygenation and intubated them. So essentially, to sum that up, RSI is 3 minutes of oxygen and medications given back to back and then intubation. DSI is ketamine, then oxygenation, and then paralytic and intubation. And what they found in the RSI group was really high rates of hypoxia, like even higher, like almost double what we see in the general population. In these agitated trauma patients, 35% of them became hypoxic, and their first pass success was really low, below 70%. When they took some time and slowed down and sedated the patient, their first pass success went up to 83% and the hypoxia plummeted to 8%, which is way less than the average. Remember, we saw 8% in the pre-oxy trial with BiPAP. So some EMS agencies and MPDs would even argue, maybe we should do DSI for everyone and maybe we should do BiPAP for everyone. And those two things combined may further reduce hypoxia. I think it's a valid argument. I like to see some good control trial evidence to show safety in all patient populations, but I think the evidence is growing that delayed sequence intubation is definitely a great alternative, especially in patients who you're having trouble pre-oxygenating. Now, post-intubation. This is an important part of intubation because peri-intubation hypotension leads to post-intubation cardiac arrest. So remember, watch out for hypotension. Sedate carefully, but as soon as it's safe to do so, be aggressive with your sedation and be on the lookout for post-intubation cardiac arrest. Now, post-intubation hypotensive rates are anywhere between 10 up to 40% when you're intubating the critically ill patient. So a wide range, but definitely dangerous. So my priorities after intubation are first confirmation, right? My end tidal CO2, my lung sounds, knowing that I'll have some delay in my saturations, but watching that the sats are at least gradually coming up within a minute after intubation. And while I'm securing the tube, I'm reassessing vitals, resuscitating as needed, and then sedating as soon as possible. So post-intubation management should include blood pressures every 3 to 5 minutes. I should have vasopressors hung and ready if not already given. And then post-intubation sedation should be done with caution, but as soon as it's safe to do so, resedate your patients. And then a last note as you're setting up your monitor, make sure you have not only your rhythm across the monitor, but your SpO2 waveform, and more importantly, your end tidal CO2 waveform. Be monitoring skin signs and pulse frequently. But as you're bouncing down the road in the back of a medic unit, pulse checks are not going to be very reliable. But your end tidal should have a good waveform, and the numbers should be staying consistent. When patients' blood pressures drop and their peri-arrest, often the end tidal will drop. So if you have a patient whose end tidal was at 40 and it suddenly drops to 20, you need to check a pulse and ask yourself if the patient is now in cardiac arrest, because PEA looks the same on the monitor, whether there's a pulse or a normal sinus rhythm. So medication choices for post-intubation. Ketamine can be given about every 10 to 15 minutes at 0.5 milligrams per kilogram. If you have propofol or you're in critical care transport, this is a great post-intubation sedative that's given as an infusion. And then midazolam and fentanyl can be given together. If I have a patient who's hemodynamically unstable and I'm resuscitating them, the first medication that I'll give for sedation is a small bolus of midazolam, as midazolam alone is the most hemodynamically stable. When I combine midazolam and fentanyl, it has a great sedative and pain effect, but there's some synergy and I may see some hypotension. So remember, resuscitate thoroughly and then sedate your patient. Please feel free to reach out to me anytime if you have questions or comments. Thanks.